curved canals. We are really happy to have you, sir, for Tiruvalla IDA. He is blessed with 2 daughters, Dia and Disha, and his better half, Dr. Nima Maria Francis, is MDS in Oral Medicine and Radiology. On behalf of Tiruvalla IDA, I welcome you, sir, for the talk.
Thank you. Thank you, Ravi.
As IDA determine the working line, 61% told apical constriction and 33% told minor foramen. So that's all. Most of the people have a good idea of where to. And you take a pre-operative radiograph, always set 61%, mostly surround.
Can I start, Ravi?
Yes, sir. Yes, sir. Yes, sir. You can start.
Yeah. So today's topic is tips and tricks in endodontics. First of all, I would like to thank Dr. Ravi and IDA Tiruvalla for inviting me into this webinar.
Yeah, doctor, carry on.
Yeah. Successful endodontic therapy is received to be the resolution and for prevention of apical periodontitis or the retention of functional tooth. So prevention of apical periodontitis is one of the main goals for endodontics. So innovations in materials, equipment, and technique continue to sophisticate endodontic treatment procedure, enhancing the incidence of predictable clinical success. So endodontic treatment needs to consider major factors affecting its failure and perform accurate steps in tackling for a successful treatment, which if neglected or improperly done could result in failure of endodontic treatment. So my aim of this presentation is to discuss the factors affecting the success of non-surgical endodontic treatment and how to prevent endodontic failures. I will share some of my clinical tips that I got from the textbooks and also from my small clinical experience. I think this will help you in your practice also, which will help to improve the overall quality of our daily endodontic treatment. So as you all know, there are different steps. We have to get a good history, then examination, investigations, then we will come into a diagnosis. Then we have to select the case, whether it is better to go for root canal treatment or extraction. Then explaining the treatment to the patient about his problems, risks and benefits. Then anesthesia, isolation, removal of caries or defective restorations, occlusal reduction as required. If you are planning for a full coverage restoration, you have to give an occlusal reduction also, so that the patient will not experience much pain after the first visit. Then pre-endodontic buildup is a very good technique. Then we have to do an access opening, working length determination, shaping and cleaning, obturation. Then another important part is coronal sealing and good access restorations. So first of all, in the examination part, we have to examine the color, contour, and consistency of both hard and soft tissue. Is there any color changes like erythematous changes? Then contour, is there any swelling, fluctuations, consistency, any fluctuations? For both of the hard tissue and soft tissue, we have to examine. If it is hard tissue, whether there is any bony expansions, any color change for the tooth. In the hard tissue, we have to examine both the tooth and the bone part. Then any relevant anatomical variations or morphological variations like dense invaginatus, as you can see some protuberance like enamel protuberance is there. Sometimes these type of problems may cause necrosis of the tooth even though there is no visible caries. This is dense in dentine. Here also you can see in the radiograph.
Frency sir.
Yes.
Frency sir.
Yeah.
Sorry to interrupt you, sir. Sir, screen share. Sir, the screen share.
കിട്ടുന്നില്ല അല്ലേ?
ഇല്ല, വന്നിട്ടില്ല സാറേ.
ആക്ച്വലി രവിരാജ് ഡോക്ടറെ എനിക്ക് കാണാം.
ഓക്കെ വന്നിട്ടുണ്ടല്ലേ? ഓക്കെ then it's my problem. No problem sir. Sorry sir.
Okay. Then dense in dentine, as you can see in the radiograph also some difference in the coronal part. If you see such things in the radiograph, you should always suspect dense in dentine, and the clinical examination also shows this type of protuberance and grooves. Then another important finding is palatogingival developmental groove. It is usually seen in case of maxillary lateral incisors. Usually in the palatal aspect, you can see a groove that is running from the coronal part into the radicular part. And many times when the patient comes with pain, if you are taking a radiograph, you can see a lesion mimicking a endoperio lesion, and there may be a deep narrow pocket in the parietal aspect also. Sometimes it may mimic a vertical root fracture also, but usually vertical root fractures will be associated with a endodontically treated tooth. But palatal-gingival grooves usually will be problems will start even before the root canal treatment. So say if you are even though you are doing only root canal treatment, in such cases it won't give any result. So usually it may cause a periodontal problems. So sometimes it may need an extraction, or sometimes it may need a flap treatment along with the sealing of this groove. So usually this type of palato-gingival groove may mimic a vertical root fracture. We can differentiate it by examining these grooves and also a deep narrow pocket. Then transillumination is nowadays the crack is very common. Usually, many patients will have some psychological stresses, tensions, etc. And many times the patient comes with crack. So crack is very difficult to diagnose in the early stages. So transillumination is a very good test. If you are having a fiber optic handpiece, you can use that light also for this purpose. So when you are, you have to give the illuminate the tooth from the incisal or occlusal aspect, and also from the buccal and lingual aspect. So in the second picture, you can see when you are illuminating the tooth from the buccal aspect, that palatal part is look darker. So in this type of presentation, there will be definitely a crack will be present, because the crack will interfere with the light propagation, which causes this dark phenomenon. So if there is a crack, the crack will not allow the light to pass from the buccal aspect to the lingual aspect. Here also you can see such cracks. So heavier amalgam restorations sometimes will come with cracks. Here also you can see when you are illuminating from the occlusal aspect, you can see a crack. Then palpation, you have to palpate. Many times we do inspection, then directly we are going for percussion. We don't palpate. Many times, even though the patient may not have a percussion pain, if the patient is not able to identify the sources of pain, just palpate. Palpation is very important. Many times, even though there is no percussion pain, you will get the tooth that is causing the pain by doing a good palpation. You have to palpate both the apical area and the cervical area. Then in infected cases, you have to look for the lymph nodes also, bimanual palpation of the lymph nodes. Then very important test, nerve stimulation tests like heat test and cold test. Heat test you can do with gutta percha sticks or heated instruments. Dental GP stoppings are available like this. You can heat it and apply on the tooth. Before applying this, you can put a small amount of Vaseline over the teeth in order to prevent the sticking. If the patient's main complaint is heat, you can go for heat test because it is very sensitive test. Then you can use this type of Profi cup to generate heat also. Then electric pulse test, if you are having electric pulse test, you can use electric pulse test also. Then one of the main test is cold test. This is very specific for irreversible pulpitis. This type of sprays are available, which gives much more easier way of testing the tooth. You can apply over a earbud and apply to the tooth that is causing the pain, or else you can use this type of anesthetic carpules to make ice in the form of some small cubes or cylinders, so that you can specifically apply over the tooth. But these type of sprays, that is Endofrost from Coltine or Endo Ice from Hager, these are very useful. There are a lot of incidents. Many times the patient may come with pain even after root canal treatment, or the patient may not be able to differentiate from where the pain is coming. Usually the patient will only point towards a root canal treated teeth. This was such a case. Actually, the patient came after a root canal treatment completed from another clinic 2 weeks before. Actually, one was re-RCT as per her history. And she was saying that even after a root canal treatment, she was having severe pain and sensitivity to cold and heat. So when I examined all the root canals, were radiographically and clinically, when I tested with the cold test also, heat test also, they were looking normal. But in the premolar, there was a heavy restoration. and it was slightly hyper-responsive, but not so problematic also. Opposing tooth also, there was some restorations that caused some hypersensitivity, but not severe. But when I examined the canine, it was look normal only because it was having a tooth color restoration, but I haven't noticed that. But when I put the cold test on the canine, she experienced severe pain. So when I took the radiograph, in the second radiograph, you can see there is a tooth colored restoration on tooth 3. Tooth 3 was slightly rotated also, so that I couldn't appreciate the restoration, and the tooth 3 was the problem. So all the days she was blaming the dentist. uh, she was saying that she was having pain even after root canal treatment. But now the problem is the canine. So many times, if the patient is having some history of root canal treatment, if the any pain comes from that area, they will point to that tooth only. In such cases, you can differentiate the pain. And one main advantage is that uh, even though if you are simply saying that after taking the X-ray, this is the problem, they won't uh, admit that. Ask the patient to hold a mirror and then just do this cold test. Then they will appreciate. So cold test is a very good test. Then sinus tracing with GP point. Sometimes if a sinus opening comes with a multi-unit bridge or a multiple root canal treated tooth, you can use the sinus tracing. It will point towards the problematic tooth. It is a very helpful tip. You can insert a 25 or 30 size GP into the sinus and take a radiograph. It will point towards the focus of infection. Then periodontal probing also is very important, because sometimes it may be a periodontal problem or a palatogingival groove or a vertical root fracture. So periodontal probing is also very important. Then you have to check the mobility of the tooth by two instruments. Then percussion, lateral and vertical percussion, as you all know. Then cusp to cusp percussion is also needed, because many times cracks, you have to do this uh, cusp percussion. Then bite test is very important to detect any cracks, because many times even though the filling is not deep, or even though the clinically the tooth is look normal, the patient may come with pain. In such cases, you can use bite test. Then test cavity and anesthetic test is also can be used as a last resource. So this is a typical picture of crown originating fractures, very difficult to diagnose in the early stage. These type of devices are not easily available in India. A fract finder and a tooth sleuth can be used for bite test, because one advantage is that they can specifically applied over each cusp. So, the main problem with the crown originating fractures is that X-ray beams run parallel to the fractures. If it is a parallel fracture, it becomes readily visible on the film. But if the fracture lines that run in a mesiodistal orientation, it will not be easily visible radiographically. That is the problem to detect crown originating fractures. Here, the fracture is located in a buccolingual direction, so that it is easily visible. So suppose you are doubting a tooth that may have which is having a crown originating fracture. What you can do is that you can do a diagnostic banding. Just band, and if the patient is asymptomatic, you can go for a direct crown also. But if the patient is having again symptoms, either you have to go for a root canal treatment or an extraction. Then a vertical root fracture is another type of fracture which sees in the root part of the tooth. Usually it is associated with a root canal treated tooth or post placed tooth. Usual clinical symptoms are a sinus opening that is close to the gingival margin, or multiple sinus opening. If it is seen directly opposite to each other, sometimes it may be a complete fracture that is running mesiodistally or usually buccolingually. Then a deep narrow pocket is a typical finding that is seen with vertical root fracture. These are some of the bone resorption patterns. Sometimes it may be an isolated bone loss directly opposite to the fracture line, or sometimes it may be a deep narrow pocket. This is the typical picture that shows the deep narrow pocket. When you are walking the probe around the tooth, you will get a sudden dip directly opposite to the fracture line. So vertical root fracture sometimes may mimic a palatogingival groove defect in case of maxillary lateral incisors. So how to differentiate between a periodontal pocket and a pocket that is developed from vertical root fracture? Periodontal pockets are usually a little bit wider and gradual, but the vertical root fracture pockets are sudden dip, that is deep narrow pocket. This is a case that came to my clinic few days back. The patient came with multiple sinus opening. You can see 2 sinus openings and a halo-shaped radiolucency. Usually, I think the patient may have a vertical root fracture. I asked to go for CBCT or directly go for extraction. Then halo-shaped radiolucency, you can see J-shaped or halo-shaped radiolucency is a typical finding. That is a combination of periapical and perilateral radiolucency. Then in some cases, you can see hair-like radiolucent line. This is also a vertical root fracture. Then sinus opening with isolated lateral lesions may be also a vertical root fracture, or it may be a missed lateral canal. Then separation of the segments in later stages, you can see this type of picture in the radiograph. So when you are exploring surgically, you can see a lot of granulation tissues with a bone defect. And if you are removing that granulation tissue and staining the tooth with methylene blue, you can see the fracture line. This is the deep narrow pocket. You can see the fracture line also directly in the coronal part. So difference between the crown originating factors and vertical root fracture is that crown originating factors are difficult to diagnose. The symptoms are sudden onset, sharp pain on chewing, and occasionally rebound pain, that is pain that is occurring when the biting pressure is relieved. Vertical root fracture, the pain symptoms are gradual onset, and usually the patient will complain about some difficulty or soreness in the fracture tooth. And crown originating fractures are difficult to localize and difficult to visualize in the radiograph, whereas vertical root fracture are more easily recognizable and more easily identifiable. Because the crown originating fractures lines usually run in a mesodistal direction, so the X-ray beams travel perpendicular to the fracture, so it is difficult to get in the X-ray. But in vertical root fractures, fracture lines usually run in a faciolingual direction, so that the X-ray beam travel parallel to the fracture lines. Then you have to check the occlusion and whether there is any high points in the restoration itself, etc. Then preoperative radiographic assessment like mesodistal tilt of the tooth is very important, because sometimes the tooth may have a distal inclination. In such cases, if you are don't consider that part, it may cause perforation. Size and shape of the pulp chamber. Sometimes the pulp chamber will be big. It will have more occlusal gingival depth, so that you have to go more deeper. Thickness of the roof of the pulp chamber, presence of pulp stones and calcifications, variations in the number of canals and root, then extent of root canal curvature, then radiographic changes in the furcation and periradicular region. All these things are very important. Then for holding sensors, you can use these type of holders, where many type of designs are available. Then preoperative reading of the radiograph, revealing the complex root canal anatomy. In this, you can see it is a premolar with the 2 roots. Then taurodontism, sometimes the crown will be grown in the more than that of the root, so that you will get this type of picture story. This is a mesotaurodontism. Then always consider the root apex status, that is whether it is an open apex or closed apex. Always consider the age of the patient and the status of the root formation before starting root canal treatment, because sometimes you will get these type of cases in your routine clinical practice. It may be a young boy about 10 years or 9 years. The patient may come with a fractured class 3 fracture involving the pulp. So if they are coming directly in your clinic, don't start root canal treatment. If the root formation is not complete, you have to go for vital pulp root canal treatment, like pulpotomy, so that you will get a root closure. So do not jump into the root canal when you are seeing a young patient or open apex cases. Then slope, as you all know, same side lingual, opposite side buccal or tube shift technique is a very good technique in endodontics to differentiate between the root canals. Here also you can see tube shift technique helps to remove the zygoma shadow. This is a common problem that we seen when you are taking the radiograph of upper second molars. You can see the shift technique will helps to remove the zygoma shadow. Also, when you are taking the radiographs like overlapping canals, you can see this tube shift technique, which helps to differentiate between the buccal and lingual roots. Then, if the patient is having severe trismus, you can use this type of technique, that is extraoral film or sensor placement. It is placed on the cheek, and we have to increase the exposure time, approximately double the exposure time. And usually maxillary teeth, you have to give a 45-degree negative angle, and mandibular posterior about 35-degree negative angle. Then always have this picture in your mind, because the radiographic apex and actual apex may be different. Many times it may exit in the side way, so radiographic apex is not the anatomical apex. Some difficult cases, you can go for CBCT or 3D imaging. Here also you can see it's the first picture, it mimicking a internal resorption. In such cases, first you have to take a normal radiograph with a shift. If it is an internal resorption, it won't shift. But if it is a external resorption or any other anatomical abnormality, it will shift. Actually, this picture is a canalis cyanosus. Actually, it is mimicking a root resorption, and it is a normal anatomical variation of anterior superior alveolar neurovascular bundle. So in CBCT, you can see it is normal. And also, when you are examining root fracture, the beam angulation plays an important role. In some second radiograph, you can see a clear fracture. In another IOPA, you can see multiple fracture line, which is due to the improper angulation. Here also in the radiograph, it looks like a normal, slightly oblique fracture, but in CBCT, you can see the extent of fracture. Here also in the CBCT, you can see a root fracture. Then lesions, internal resorptions, all these things can be nicely visualized in CBCT. This is a picture of external resorption. Then periapical lesion extent and healing after a root canal treatment, all these things can be visualized in CBCT. Then CBCT is a very useful aid in difficult root canal anatomies also, to differentiate, identify the root canal anatomies. So, and always many times, many other anatomical, normal anatomical variants or other pathologies may mimic an endodontic lesion. So always check the vitality, give a tube shift technique, always examine the lamina dura. All these factors will help to differentiate between a normal variant and lesions of endodontic origin, and also to differentiate between lesions of endodontic origins from other pathologies. So systemic evaluation of all anatomical structures, systemic evaluation of radiograph and pathological parameters, then determination of etiopathogenesis of development, reactive and neoplastic will help to in the differential diagnosis. Then, as I said earlier, it is very important to consider the stage of development of tooth development. I have seen many of my friends, even in a young patient, they will start the root canal treatment and without an IOPA in a very young patient, if you are seeing a direct pulp exposure. Then after that, they will become confused what to do now, because it is an open apex. So if it is a vital pulp, always would go for a vital pulp therapy like pulpotomy. So the choice of treatment depends upon the stage of development of tooth, time between the accident and treatment, concomitant periodontal injury, and also restorative treatment plan. Sometimes there may not be any direct pulp exposure, but the restorative plan, like if it needs a post-encore, you have to go for interventional root canal treatment. Then suppose the open apex tooth is having a non-vital pulp, then you can't rely on vital pulp therapy. You have to either go with conventional apexification with calcium hydroxide, but it is a very time-consuming procedure. Nowadays, many other good techniques are available. If it is almost closed, but if it is but with a wide open apex, you can go with apical barrier with MTA or biodentate, so that it is a single-step apexification procedure. So you are artificially closing the apex, then you can directly go for obturation. Or if it is a severely immature tooth, you can even try with revascularization technique to get the root closure. Then many times the patient come with sinusitis also. Some sinusitis may be associated with the endodontic problems also. Here you can see it is called periapical osteoperiosteitis. If it in the CBCT scan or CT scan, you are seeing such a picture. You can see there is a bone deposition that is lifting the membrane. It may be a periapical osteoperiosteitis. So the apical periodontitis displaces the periosteum into the floor of maxillary sinus, and the inflamed periosteum deposits a thin layer of newly formed cortical bone on the periphery as the lesion expands. So it is called periapical osteoperiosteitis. This is a picture of CT. You can see periapical osteoperiosteitis. And another one is periapical mucositis. There is no bone deposition, but the apical periodontitis perforates the antral cortex and associated periosteum, causing a localized inflammatory edema in the adjacent sinus mucosa. The inflammation caused the rupture of the membrane, and there is a mucosal deposition. You can see in the second picture, you can see the mucosal, slight mucosal radiopacity in the CT scan. And after endodontic treatment, it was completely regressed. So sometimes, actually, in this textbook, it has written that it was posted for the surgical treatment, but luckily it was completely got resolution by endodontic treatment also. So also non-odontogenic toothache, chronic head and neck pain, TMJ pain, and trigeminal neuralgia, all these things you have to differentiate. Then when you are before doing treatment, always ask the patient to hold a mouth mirror, or you can even use a intraoral mirror, but this is the best way. You can show the tooth, this is the problem, this is the tooth that requiring root canal treatment, so that you can many times you can avoid the problems with the patient at a later stage. Many times the patient say, actually I was not having pain in this teeth, like that they will tell. Do a prior assessment of root canal curvature based on preoperative radiograph and assess the difficulty or risk associated. Many times, tooth, if you are taking a preoperative radiograph, you will get an idea whether this root canal treatment will be a easy one or a difficult one. Sometimes there may be severe calcification, curvatures, anatomical variations. So then, according to your ability, you can judge whether I can do this root canal in a proper way, or should I refer this patient, or should I call an endodontist. So sometimes we need an extra support. That is why we need interdisciplinary dentistry. So even though you are doing root canal treatment in your daily practice, you can get a help from some other persons if you need. Evaluate the radiograph. But one problem with the 2D radiograph is that only the curvatures in the mesiodistal plane can be seen on the radiograph, though the curvature in the buccolingual plane are also common in many too. For example, palatal roots of maxillary molars often have a buccal curve, whereas maxillary lateral and mandibular incisors may have lingual curves. So maxillary lateral incisors usually have a palatal curve, mandibular incisors must have a lingual curve. All these things you have to have in your mind, so that it will make your root canal treatment more easy. This is the picture that shows the buccal curve of the palatal root of the maxillary molar. So many times what we see in the radiograph may be only a small part of the picture. Then determination of the point of penetration. This is for some of the guidelines for the preparation of access cavity. Usually the entry is at the center of the occlusal table, but in certain teeth like maxillary molars, it is deceiving, as the center of the occlusal table does not reflect the center of the pulp chamber. So these things I think you all know very well. Then assessment of the occlusal and external form. So once the point of entry has been determined, the burr angulation 3-dimension has to be mentally envisioned. Sometimes a tooth may have some lingual tilt or distal inclination. So, or there may be severe tapering towards the gingival part. So these all things have to be taken care of. This is determined by taking into account the angulation of the teeth in the jaw and assessing the external root surface at the level of CEJ. CEJ is considered to be one of the constant landmark. So sometimes the tooth may have a cervical tapering. All these things you have to take into consideration. Then radiographic measurement of the depth of the pulp chamber root from the occlusal table. So initial burr in a high-speed handpiece is placed against a radiograph for a measurement of determined from the calibrated digital image. Sometimes if it is a mesotaurodont or a taurodont, you have to go more towards the apical region. Then assessment of complicating factors. This is also very important. Rotation or tipping of teeth, calcification, deep respiration, buccal and lingual restoration. Usually buccal restorations and lingual restoration will cause a lot of calcification, and it will be very difficult to identify the canals. There will be a lot of coronal calcification if it is there a buccal lingual restoration. Root length, width, and curvature, then angle of entry, degree of extension of the access cavity, all things we have to look into from the radiograph. Then radiographic assessment, sometimes angle views should be taken in an attempt to visualize the breadth of the root and position of the canal within it. One has to assess the angle at which the canal leaves the pulp chamber also. Sometimes when you are seeing a radiograph, you can see there will be a severe coronal curvature. That is, sometimes although the coronal curvature seems to be very easily negotiable, if you are not taking that coronal curvature seriously, it may cause a breakage of the instrument in the coronal part, which may cause problems at a later stage. So how to understand the root canal anatomy? You can search in the internet, then read from the textbooks. You will get the normal anatomical variations. Then another important or easy technique to study root morphology is to examine the tooth when you are doing extractions. You will get the normal patterns of curvature of the root canals, roots. Then do a pre-endodontic buildup and rubber dam isolation whenever possible. Although we neglect rubber dam in many of our practice, start slowly incorporating rubber dam because it is very important. Then if you are not doing a rubber dam, at least do a pre-endodontic buildup. So suppose if you are having a very busy practice and you don't have the time to do a pre-endodontic buildup, what you can do is that after the first visit, after placing the intracanal medicament, place a Teflon, then build up the distal wall or missing wall with a glass ionomer cement, or even you can use a full glass ionomer to restore as a temporary filling. Then the next visit, you can do your access preparation as a normal access preparation. So in the second visit, it will help to hold the irrigation solution inside the canal much more efficiently. So whenever possible, do a pre-endodontic buildup in the first visit. If it is not possible, so the second way is to do when you are doing an access temporary filling after the first visit, give a glass ionomer restoration or composite restoration as pre-endodontic buildup or access restoration. Then very badly mutilated teeth, there is a technique called canal projections. Actually, it is an instrumented cord with the plastic sleeves, which can be placed into the root canal, and after that you can use some injectable core build-up material. Another economical way is to use these type of intracanal medicament delivery tips to use as a sleeves. Then access cavity, what I usually use that these type of small straight fissure burrs and round burrs to remove the caries. Usually I use small straight fissure burr, but it depends upon your choice. Then if it is a very long pulp chamber, you can use some small tapered fissure burrs also. So once you get into the entry, into the pulp chamber, you can shift into the safe and tip burrs like Endo Z burr. It is a safe and tip burr so that it won't perforate or gauge the floor. So you can remove safely the roof of the pulp chamber. Endo access burr is also a type of access burr with a combination of tapered fissuring plus rounded. But I usually don't advise this endo access burr because it is a little bit bulkier burr. You can use small burrs so that your access cavity will be much more conservative. So for preparing your access cavity, you can use small straight fissure, round burrs, and tapered fissure burrs. And for refining your access, once the pulp chamber is open, you can use Endo Z. It is from Dentsply. Then you need a good DG16 Explorer, a good spoon excavator, and some ultrasonic tips to refine the access cavity. StarTex 3 from Dentsply is a very good tip for refining the access cavity, but it is a bit costlier. DG16 and Endodontic Explorer, along with a good spoon excavator, is a must for access cavity. Access cavity should be conservative, but should not be ultra conservative. Nowadays, lot of ultra conservative preparations like Ninja access, plus access. If you are not having a good magnification, it is better to go for conservative preparation, but not ultra conservative preparation. So getting a straight line access. Then if you are not if you are not having start expiry tip, you can use other tips like RS1 and E5D. RS1 tip is from Cybron Endo. Then E5D similar tips are 3D. E5D is more useful. It is from Woodpecker. It is not very costly. Then these are safe and tip. Both diamond and carbide burrs are available. You can use this type of device to remove the roof and divert the walls if you need. Then if you are not having ultrasonic tips, you can use this type of burrs also. That is Muller burr, Ellen burr, this type of messenger burr. These are actually can be inserted into our normal micromotor or endomotor and can be used to toughen the isthmuses, chase for calcifications, etc. Then DG16 Explorer actually helps to locate the canal. Then micro openers are available. They are basically 4% device, 4% and 6% taper devices. Sizes are available like 10, 15. They can be used in difficult access areas to open the canal orifices. Then always make sure that you are extending the axial walls in the proper way, because your access cavities should not be in a mouse hole type access cavity. And once you open the access cavity, you have to always look for whether there is any presence of cracks. So because sometimes if this crack is very deep, it may cause problem. Sometimes it may lead to a failure even at a later stage. And when you are examining the morphology of the tooth, suppose if you are having some abnormal or a wider mesodistal dimension or buccolingual dimension or prominent cingulum or cusp, you have to doubt some extra canal, because sometimes in the maxillary premolar or mandibular premolar, the buccal or cusp may be a little bit wider. In such cases, you have to go look for additional buccal canals. Then color change. Enamel is usually white, dentin is yellow, as you all know. And the floor of the pulp chamber is much more darker. And root canal orifice also dark gray or black, white or dark yellow in color. Then there are some rules for access cavity, very famous, Krasner or Rango. I'm not going into the full. The main laws are laws of centrality. That is, the floor of the pulp chamber is always located in the center of tooth at the level of CEJ. And CEJ is the most consistent and repeatable landmark for locating the position of the pulp chamber. So always make sure, note the point that CEJ is the main landmark. Then law of color change. The color of the pulp chamber floor is always darker than the walls, and the root canals are located at the terminus of the developmental fusion lines. So these are some of the important laws. You can see the floor is slightly darker, and you can see the dentinal map also. So these are some of the common errors. So always make sure that you are not directing the burr. Should always direct the burr parallel to the long axis of the tooth. Always consider the angulation of the tooth. Here also you can see, and also in lower anteriors there will be a chances of missing lingual canals. So you have to give a lingual curvature to the file and always try to catch the lingual canal. And sometimes the normal anatomical landmarks may mimic a periapical lesion. You can look for the widening of the periodontal ligament and also check the vitality if it is a normal tooth. If it is a vital tooth, it may not be a lesion of endodontic origin. And also give a tube shift technique. And if the lesion changes its position, it may not be a lesion of endodontic origin. Then always consider should be very careful if it is a tilted tooth. Here also in mandibular premolar, there will be a lingual canal. Chances of lingual canal is very high. And maxillary incisors, when you are opening from the lingual aspect, you have to remove the lingual shoulder also. Actually, you can see if you are starting from the incisal edge, you will get a more straight line access, but it is not possible many times because of the aesthetic problems. So when you are opening from the lingual aspect, remove the lingual shoulder also. The lower anteriors, always, especially if it is a narrow canal, you should take repeated radiograph. Sometimes if it is a calcified canal, after opening slightly into the axis, you can take a radiograph and make sure that you are going in the proper direction. Because even a slight change in the direction may cause unnecessary damage to the tooth. Then use very small burrs. Then always look for the lingual canal. The lingual canal may be occurring at a sharp angulation from the coronal aspect. So always look for the lingual canals. Here you can see a RCD, you can see the lingual canals, a lower anteriors. Then here also a lower anterior intentional RCT after a trauma. You can see two canals with separate portal of exit, which is not very common in lower anteriors. Here also you can see multiple, most of the lower anteriors are having two canals. Then this is a maxillary canine with two canals with a lesion. Then mandibular premolars are notorious for lingual canals. You can see lingual canal. Always give a pre-curve to the lingual, to your K file, and search for any lingual catch. Mandibular first premolar, always make note that the crown is little bit tilted lingually relative to the root. So these things you have to take into consideration, and your access cavity should be directed from the central pit towards the buccal cusp slightly rather than going towards the lingual cusp in case of mandibular first premolar. So entry point is at the middle third of the central groove, and the burr is directed to the buccal aspect so that you will get the straight line access. This is the picture that shows the lingual canal from the mesial and distal view. So you can see, like lower incisors, there will be a sharp curve. You can see lower premolar with two canal morphology. Here, this is a referred case. Actually, the practitioner got the idea that the tooth is having some additional canal. So you can see in the radiograph, there is some division or split of the canal. Sudden disappearance of the root canal outline will give an indication of the division of the canal. So slight pre-curving into the lingual aspect will help to negotiate the lingual canal. Then give a good coronal flaring in that curve part with some files. Then you can operate that canals. So many times there will be a sharp lingual curve. Then three canal morphology of first premolar and second premolar is also very rare. In three canal morphology of lower premolar, there will be two buccal canals and one lingual canal. In lingual canal, you can see a curve also in the apical curve. Here also deep split of first picture, you can see a deep split of mandibular premolar. Then sometimes there will be a coronal, from the coronal aspects itself, the canal divide. And sometimes there will be two canals that may be joining into the apical region, and you can see the isthmus between the buccal and lingual canal. Here you can see a sudden disappearance of the root canal outline from the middle third. There is a deep split of the lower premolar. Here also you can see sudden disappearance, and you can see deep split with the two root in the apical region. Here also you can see a line running from the middle third. It is an indication of the small lingual canal. In the radiograph, it may mimic as a distal root, but you have to go for search for the lingual aspect. Here also you can see the lingual canals. Here also an additional lingual root. Actually, in this patient, most of the tooth is having some additional roots. Molar also you can see a radix or separate distal root. Here also you can see sudden disappearance or fast breaking appearance of the root canal outline. Then here also endoperioral lesions referred case, you can see two canal morphology. Then multiple portals of exit is very common in the case of mandibular premolars. A good irrigation and good obturation technique will help to operate these type of anatomical complexities. Although the premolars may look very easy, lower premolars are called endodontic enigma because they are much more prone to cause root canal failures. Then isthmus connection between the buccal and lingual canals of or mesial and distal canal. Usually buccal and lingual canals of maxillary premolars will have such type of isthmuses. If it is a coronal isthmus, you have to widen it and clean it with hand files and irrigation. This is a picture that shows the maxillary premolar with the two or three canal morphology. Here you can see the buccal, mesiobuccal and mesiolingual canal. It is a mini molar type of premolar. This is the picture that shows the maxillary premolar with the three canals. Here you can see maxillary premolar with the three canals. Here also a deep split of the buccal canal. Here also you can see the division of the canal from the middle third. Here also you can see maxillary premolar with a 3 root. In the first X-ray, you can see after the operation, when I took the radiograph, I realized that there may be a missing canal because there is some radiolucent line, and also one master bone is shifted towards one side. So there may be, I re-entered the tooth and I could find the second or distobuccal canal. Here also you can see a mini molarized premolar. Here also you can see 2 roots, 2 canals in the buccal aspect. So it is a, sometimes you will, from the preoperative radiograph itself, you will get an idea. This is also 3-rooted morphology. Then upper first molar, you have to take into the consideration of the cervical tapering of the tooth. Otherwise, if you are going straight, sometimes it may go cause a perforation in the gingival aspect. So always direct centrally and slightly towards the distal aspect, and also look for the MB2 canal. MB2 canals are usually located very close to the MB1 canal, and sometimes both of them may originate from the same orifice also. Usually it is slightly parallel to the mesiobuccal cusp and slightly mesial to the MB1 orifice. If you are drawing a line from the MB1 to the palatal canal, usually this type of MB2 will be located in that line or slightly mesial to that. So this is the location of MB1 canal. Then always do a pre-curving and always search for the MB2 canals. This is the typical picture of the MB2 canal. And if you are missing an MB2 canal with a separate portal of exit, it may cause problem at a later stage. This is another picture, MB2 with separate portal of exit. And sometimes MB2 will act as a hero also, and sometimes it acts as a villain also. Actually, this is RCT treated teeth. Actually, it was my orthodontist, and the patient doctor was having pain. And when I took the radiograph, you can see there was some separated instrument in both in mesiobuccal and distobuccal group. Looks like some H file. I started a selective retreatment of mesiobuccal and distobuccal. Although I tried to bypass the mesiobuccal and distobuccal, I couldn't achieve that. So when I looked for the MB2 canal, and through the MB2 canal, I could reach the apical region, and I operated the canal. So actually the lesion healed after that. Here also you can see a sharp curvature with calcified mesiobuccal root, but there is a separate portal of exit for MB1 and MB2. So in such cases, if you miss a MB2 canal, it may cause persistence of the lesion. Here also a rear root canal treatment and root canal treatment of maxillary first molar. You can see both first molar and second molar are having separate portal of exit. Here also you can see MB2 with a sharp curvature in distobuccal root. Here also MB2 with separate portal of exit and sharp curvature. Usually if the MB2 is separate, usually some type of curve will be there. Here also upper 7, you can see sharp curve in the mid root region with MB1 and MB2 with separate portal of exit. Here also you can see MB2 with separate. Sometimes there may be an MB3 canal, but usually it may be joining with other MB mesiobuccal canals. Here you can see the MB1 and MB2 and MB3, but they are joining together. MB3 is joining with MB2. Here also 2 separate canals. Then sometimes here also you can see 3 canal morphology, but you can see the apical MB1 and distobuccal canal are joining with some apical delta. So sometimes the upper 7 you can see this type of picture also. This is also MB3 canal, but all these canals are joining in the middle third region. So if you are giving this type of shift, usually a distal shift will help to differentiate between the MB1 and MB2. Slightly give a distal shift. If it is not working, give a mesial shift. But majority of the time, you will get if you are giving a distal shift, you will get this type of separation of separate MB1 and MB2. Sometimes there may be an additional palatal canal also. Sometimes it may be joining, or sometimes it may be separate. So sometimes the maxillary molars may have a bifurcated or double palatal root. Here you can see some variations in the anatomy of a maxillary first molar. You can see 4 separate roots. So 2 palatal canals were there. 2 palatal roots are also there. So this is the 2 palatal canal orifices. Sometimes the second molar, the mesiobuccal and distobuccal canal may originate from the same orifice. You can see the mesiobuccal and distobuccal are originating from the same orifice. Here it is an upper 8. You can see 4 canals are there, 3 canals are joining. Here also in the preoperative radiograph also itself, you can see some difference. Actually, it is a 4 canal and 4 rooted morphology. 2 palatal roots are there for this third molar, upper third molar. Then lower molar, you have to always look for the middle mesial canal, isthmus between the middle mesial and distal canals. Mesiobuccal and distobuccal canal, and distobuccal and distolingual canal. Then middle distal canal or second distal canal. That is, sometimes you may get distobuccal canal, but you may miss the distolingual canal, because sometimes it may be an oval canal, oval orifice, and distolingual and distobuccal canal may be originating from the same orifice. So when you are doing a root canal treatment, shift the instrument angulation. Always search in different angulation so that you won't miss the distolingual canal also. And also roughen the isthmus between the canals and look for any middle distal and middle mesial canal also. And sometimes the distal canal may have a distal curve. Usually the distal canal have a distal exit in case of lower molars. So if you are getting a sudden stop in the distal canal, give a distal curve to the file so that the patency will be easily get. Here you can see the distal exit of the distal root. Here also you can see the distal root having 2 distal portal of exit. Sometimes you may have 2 mesial roots for the mandibular molars. It's not very common. Then mandibular first molars, access preparations often approach the buccal cusp tip, that is mesiobuccal, but rarely onto the lingual. Your access preparation should be slightly towards the buccal. That is, the access will be located largely in the mesial half of the tooth, and you have to slightly extend towards the mesiobuccal cusp to get the mesiobuccal canal. So even if it is the mesiobuccal canal orifice is little bit more towards the buccal aspect, you can just widen that area only. That is called shamrock preparation. Just give a clovelly appearance to the access cavity, not so that you can save much tooth structure. Then mandibular first molars, the groove between the mesiobuccal and mesiolingual and distolingual canal must always be roughened with burr. So you can use burrs like Ellen burr, or you can use ultrasonic and check with the files to search for the mesial canal. Roughen the isthmus and then try to get a catch with the hand files, DG16 Explorer, etc., so that you can get middle mesial and middle distal canal. And sometimes the second distal canal, always change the direction of hand file, as I said earlier. Then radix endomolaris, that is additional distolingual or distobuccal root. Usually the distolingual root is the most common, and many times these type of root will have abrupt apical curvature, which may not be seen in the radiograph. Usually this type of curvature will be in the buccal direction. And radix endomolaris is very notorious for instrument separation. The additional distolingual canal may be very narrow, or sometimes it may have an acute apical curvature. So always should be very careful when you are instrumenting radix endomolaris. Use lesser taper instruments and do a very good hand instrumentation by pre-curving the instruments. This is such a case. You can see I have separated one instrument in the distolingual canal. Luckily, I could bypass. Here also, in the distolingual canal, actually it was having buccal curve, which is not easily visible in the radiograph. Here also in the additional canal, I have separated one instrument. And this is the picture that I said earlier. Many times in the distal canal, you may miss this distolingual canal. You may get the distobuccal canal or one canal. So you have to change the direction and always check the additional canal in the buccal and lingual direction, and also search for the isthmus. Also in lower second molar, if you are getting 2 canals, also sometimes you may get an additional lingual canal. From the same orifice, the mesiolingual canal may be originating deep from the same orifice. So always give a lingual curvature and look for the additional canal. Then middle mesial canal. Here, first picture you can see 4 orifices. Another pictures you can see 3 orifices. So middle mesial canal usually located between the mesiobuccal and mesiolingual canal. Majority of the time it may join with the other mesial canals, but sometimes it may have a separate portals of exit. So these are some of the pictures of the middle mesial canal and middle mesial isthmus. So if you are seeing a furcation radiolucency or halo-shaped radiolucency, it may be an indication of the furcation canal's deep isthmus or middle mesial canal. Suppose if it is not a root canal treated tooth also, although it may mimic a vertical root fracture, you can doubt this also. That is, furcation canals, isthmus between the middle mesial canal or middle mesial canals. These are some of the tips that will help to locate the additional canals. Always look for a catch between the, I am explaining in this scenario, that is the middle mesial canal, but this can be used for every cases. Always look for a catch in between the mesiobuccal and mesiolingual canal, and use ultrasonic tips like StarTex3 E5D or RS1 from Cybron at low power to widen the isthmus or the suspected area of canal. Use it in a very low power. Slightly irrigate to remove the debris and to cool down the area. Then use DG16 Explorer, then number 8 and 10K file for initial exploration. Try to get any catch in that area. Then ProTaper S1, this is a very useful tip. ProTaper S1 21 mm, the conventional universal ProTaper can be used as a last resort at a very slow speed to get a catch in the possible locations of additional canal. Use it in a speed of 200 to 250 RPM with a torque of 1.2, 1.5. Then try to get some catch. If you are getting a catch, don't try to go into the apical region. Just widen that orifice, then use the hand files again. Once the catch is obtained, use small K files for coronal enlargement with EDTA gel. Enlarge the coronal third with the rotary files, that is ProTaper S1 can be used for coronal shaping also. Then slowly try to reach the apex using 8-10 K files and then take working length, and instrumentation should be proceeded as the normal protocol. Then find the nature of the canal configuration. As I said earlier, many times these type of additional canals may be joining with the main canals. So, and these type of canals may be very narrow also. So before instrumenting these additional canals, once you located this canal, you can instrument the main canal and find the canal configuration, whether these type of canals are joining with the main canals. If it is joining with the main canals, no need to put the rotary instrument into the apical thread, because it may cause unnecessary stresses on the instrument and cause instrument separation. So adjust the instrumentation sequence accordingly. How to find the nature of canal configuration we will discuss in the following slide. And if these additional canals are very narrow and it is having separate portals of exit, use very small size rotary files, very small taper files. So use glider files, 4% files will be very useful for such cases, because in this case you can see 3 port middle mesial canals are there with separate portal of exit. So if you are using 6% file in all these canals, it may cause a lot of rupture or a destruction to the root structure. And usually, as I said earlier, for mesio MB1 and MB2, a slight vertical distal shift with minimum vertical angulation will usually helps to reveal the middle mesial canal. Usually, the distal shift is the most useful technique, but if it is not working, you can give an exaggerated mesial shift also. Then furcation radiolucency may be an indication of isthmus or middle mesial canal. Here also you can see furcation radiolucency and mid-root radiolucency, and this is a metapex, some amount of extrusion happened. Here sometimes C-shaped canals are very common in second molars and third molars. And the second picture you can see the mesiolingual canal is originating very deep from the same orifice. In the clinical picture there was only one orifice, but mesiolingual canal is originating deep from the mesiobuccal canal, about from the middle third region. So always look for the mesiolingual canal, even though you are getting two big canals, that is one mesial and one distal canal. From the same orifice of the mesial canal, there may be an additional canal. Here also you can sometimes the C-shaped canals. The lower second molars are very diverse. C-shaped canals, mesiobuccal or mesiolingual canal joining with the distal canal. Then this is the second molar with the additional mesial root. This is the third molar. You can see in the picture, distal root, you can see some difference. Actually, the distal root is having 3 canals with a separate portal of exit, but the mesiobuccal canal is joining with the distal canal. Here all in the distal root, you can see some difference. So then use dyes like methylene blue can be used to detect the additional canal. If it is a vital pulp, it is very useful. After removing the pulp from the main canal, you can dye the pulp chamber and look for additional canals like MP2. Then fill the pulp chamber with hypochlorite. And if you are seeing some bubbling from the orifice, you can detect the additional canal, especially it is very useful if you are having magnification. Then deep splitting of the root canals is very common. So if you are when you are instrumenting, if you are getting some difference when you are instrumenting in different directions, you have to doubt the deep splitting of the root canal and give a pre-curve to the instrument and try to negotiate that canal. And very difficult canal, you can go for the CBCT also. Here you can see a lower premolar that with a apical periodontitis. So when RCT started, there was a deep split. These are not easily visible in the radiograph, but you can get that feel. I was not able to place simultaneously inside the canals. So you can see the three cones are not simultaneously going. So I operated the first two canals. Then I used the technique called ultrasonic compaction to remove the coronal part of the GB. If you are having warm vertical compaction unit or continuous wave of compaction unit, you can use that technique. Then I place the other cone in the next canal and operate. Here also, you can see the deep split of the lower premolars with some isthmus. Then maxillary premolars, you can see deep split with isthmuses. Suppose if you are getting the palatal canal very easily, and if you are not getting the buccal canal, or if the instrument is not going beyond the middle third very easily, you should always suspect an additional buccal canal or division of the buccal canal. This type of problem usually occurs in case of maxillary premolars. Sometimes you are getting lot of resistance in the buccal canal in the middle third or coronal third region itself. You should suspect an additional canal. Then always remove the lingual shoulder when you are doing a root canal for anteriors. And angle of penetration when you are doing a root canal for multi-rooted tooth should be towards the largest canal. That angle of penetration for maxillary molars towards the palatal root and mandibular molars towards the distal root. And always consider the angulation of the tooth, then tilt of the tooth. Then maxillary second molar, sometimes the distobuccal canal may be lying in a straight line between the mesiobuccal and palatal canal, or sometimes it may be two canal or single canal morphology. Then mandibular molars, always look for the second additional canal and rectangular outline form of the mandibular first molar. And usually the mesiobuccal canal will be located under the mesiobuccal cusp, and the mesiolingual canal lies centrally in relation to the crown. Then C-shaped canals. These are some of the CT pictures that shows the C-shaped canal. You can see the anatomical complexities. C-shaped canal, you have to rely upon much more on irrigation. This is also a C-shaped canal. So if you are finding some abnormalities like this in preoperative X-ray, or if you are when you are placing the master cone, you will see that you may get the feeling that your master cone is going into the furcation area. Sometimes it may be a C-shaped canal, or this is also a C-shaped canal. Here also you can see a C-shaped canal. This is a maxillary first molar with a C-shaped canal. It's a very rare anatomy. Then isthmus between the canal. There are different types of isthmuses. So you can see if it is a very deep and narrow isthmus, it is very difficult to fill. The mandibular canine with isthmus, maxillary premolar with isthmus, then mandibular molars with isthmus. Here also a deep isthmus. There was no coronal communication in a mandibular second molar. Here also you can see a isthmus between the mesiobuccal and mesiolingual canal and the third distal canal. Here also you can see the mesiobuccal and mesiolingual canal are having isthmus between. Here a young patient, usually there will be a lot of isthmus. Here you can see a young patient in mandibular first molar, both in the distal root and mesial root. You can see the isthmus. Shifted X-ray will reveal this isthmus. Then apex locators are very important for working length determination. As you all know, this is a picture of anatomical apex. So ideally we have to stop the root canal filling in the D or E region, that is the cemento-dentinal junction. Here you can see the apical constriction. So this is a picture that shows the importance of apex locator. When you are taking a radiograph, in the first picture you may get a good picture because the apex radiograph, in the radiograph it will look absolutely normal. But if you are visualizing from the mesial or distal aspect, you can see the instrument is much 2 or 3 millimeter out the anatomical apex. So apex locator is very important, and sometimes the tooth may have some distal or mesial or distal exit. So I will share some of the points put forward by Dr. Ganesh Mayura in FB. It's very useful when you are using an electronic apex locator. Isolate the tooth using rubber dam, or at least do a good pre-endodontic build-up before using apex locators. If you are not using a rubber dam, do a good pre-endodontic build-up or a cotton roll isolation. Check the apex locators and cord is functioning properly. In some apex locators, you can clip the apex locator file holder with the lip clip, and it will give a reading so that you can get an idea whether it is functioning properly. The pulp chamber should be reasonably dry, and the canal should be wet, but there should not be any active pus or blood discharge. It should not be overly wet or overly dry, the canals, but the pulp chamber should be reasonably dry. Then presence of small amount of vital or non-vital pulp, blood or irrigation solution does not interfere with the reading of apex locators. So the canals need not to be thoroughly dried like when you are going for obturation. But it is recommended to do a coronal flaring so that the file engages apically. Actually, the file binding should come from the apical end. Then only we will get a good reading. PDTA lubricant and slowly inserted into the canal in watch binding motion and should snugly fit in the apical third region. Start with the 10 file, but if you're feeling that it is not giving the perfect value, suppose if it is a large canal, the 10K file will not bind in the apical region. In such cases, it won't give a better reading. So in such cases, if you are feeling that the file is loose, take the next large file and insert inside the canal. Then metallic restorations like silver amalgam or metal or ceramic crowns should not come into contact with the file. So the file should not touch the walls of the tooth. So if you are going through the metallic processes, an insulator such as a sleeve can be used on the file to prevent the contact of the file if you are having that problem, to prevent the leakage of the current. And attach the lip hook on the moist lip and on the opposite side of the tooth that are treating, so that it won't interfere with the file holder. Apex locator should not be used in patients with cardiac pacemakers, and the reading on the graph should be gradually increase or decrease when the file is inserted and removed from the canal, rather than jumping suddenly. Then if the apex locator may showing premature or early readings in the presence, it may be a presence of perforation, accessory canal, open apex cases, or leaking of the electronic current through the gingiva. Suppose if it is a subgingival caries, etc. So if the apex locator does not show any reading, check the battery or check for any loose connection of the circuit. And if the apex locator show very short or long root canal length than the anticipated length, take a working length radiograph too. Suppose if it is giving a value like 28 millimeter or 27 millimeter in a maxillary molar, you can check it with the radiograph in that step itself. So here the electronic apex locator can be, if you are going through the processes, you can use these type of sleeves. Then determination of the root canal curvature in difficult cases, you can draw lines from the coronal aspect and second line from the apical region, and the internal line angle is called the Schneider's angle. And if it is more than 25 degrees, Schneider's angle, if it is more than 25 degrees, it is classified as a difficult or severely curved canal. The next one is the radius of curvature is very important. So the second picture, you can see the radius of curvature is small. So if the radius of curvature is very small, it is going to be a more complex case. So it is an important factor that determines the fracture resistance of the file. So as the radius decreases, the chances of fracture increases. So smaller the radius, more difficult will be the root canal treatment and more stresses will be there on the instrument. So if it is a small radius less than 4 millimeter, it is a severe curvature. So some techniques for instrumentation, always pre-curve. Placing a gradual curve for the entire length of the file will be useful for most of the cases, because most of the root will have some amount of curvature. Even though in the radiograph there may not be any curvature visible, some amount of buccolingual curvature will be there. So placing a gradual curvature, it will be very useful. And placing a sharp curve about 30 to 45 degree at the apical end of instrument will be very useful when you are a sharp curve will be very useful for sharp apical dilacerations or distal exit, And when an obstruction is encountered, like to bypass a ledge or a fractured instrument or during a retreatment, you can use this type of sharp curvature. And you have to adjust the rubber stopper. Pointed rubber stoppers or rubber stoppers with markings are available. So you have to adjust that markings or these pointed tips in the direction of the pre-curving. And pre-curving file of both stainless steel and nickel titanium can be done with endo bender pliers, which is not easily available in India. So you can use these type of jewelry making pliers to pre-curve the file. And also you can use hand and gauze. And also this is a very useful technique to pre-curve the file. You can use the mouth mirror, round mouth mirror handles. So pre-curving of the file, the gradual curve for the entire length of the file can be used for majority of the cases. But one problem is that suppose that the root is having some severe apical curve, it is not very easy to insert a sharp apical curved instrument into the apical third directly when you are starting a root canal. So in such cases, what you can do is that in the gradual curved root, you can give the pre-curving initially itself, but in the other case too, you can give a very good coronal flare, and after that give a sharp apical curve. In case of lower molars with the distal root, with the distal apical curve, you can try with the coronal flaring first, and then after that you can give a distal curve. I'll share one case. Actually, this was started by one of my friend. Actually, there was MB1 and MB2 canal, but she was not able to negotiate it properly. She was feeling some sudden stop, but with some pre-curving, we could find the mesobuccal canal into the apical region. Here, he can see a thin slender root in the apical region. Somehow with pre-curving, I could go into the apical region, but when I when I was not proceeded, when I proceeded further, the pre-curving was not properly done, and it resulted in transportation when I went to larger instruments. Here you can see some abnormality in the root canal morphology. It's a second mandibular, second molar. Actually, it was a C-shaped canal. In the distal root, you can see the patency was difficult, but after coronal flaring and a pre-curving, I could negotiate the distal exit, and it was a C-shaped canal. So use of intermediate sizes of files. So if it is a very narrow canal, you can use intermediate size file like number 12 and 17. So usually nowadays, if it is a very narrow and curved canal, it is not recommended to go with files more than number 10 into the apical region in the initial stage itself. After the rotary instrumentation, you can use larger K files if you want, but it is always preferable to not use more than size number 10 if it is a very severely narrow apical canal. Then anti-curvature file, actually it was proposed by Aburas. Actually, basic principle is to work the endodontics instrument against the external wall of the curve. So you have to work away from the furcation area or the danger zone. This is the danger zone, mesial root of mandibular molar. You can see the thin zone. It helps to avoid the strip perforation. So when you are instrumenting, you have to work away from the furcation. Always, when you are doing post-based preparation also, you should be very careful. Then very important technique is called envelope of motion. Actually, it is a technique to instrument the hand file instrumentation, technique to be used along with hand file instrumentation. Pre-curve the file like number 10 and 15 and follow the instrument into the root canal system. And short of maximum resistance, make a clockwise rotation while removing the instrument. You have to rotate and remove so that you can insert the next instrument. So with each envelope of motion, you can create space for the next instrument. So it is a very useful technique for advancing the hand file into the apical region. Then is the crown down technique is always advantage over the step back technique. So it is many textbooks or operators says that we should always use crown down technique, but it is not always like that. The operator must interpret the resistance encountered in each portion of the canal in order to determine the appropriate instrument sequence. And it is always preferable to go for a hybrid technique rather than sticking to one technique. I will share some of the things shared by Max Padden in his book. Max Padden passed away recently, few weeks back. It's a very good book. We'll see some of the facts. If you are directly going with larger taper files or larger size files for crown down technique, what will happen? The larger taper instrument will be locked inside the smaller taper of the canal, which may cause unnecessary instrument stress and separation. Also, it may cause transportation of the canal. So you have to use smaller taper files and smaller tip file to increase the coronal file. Once a severe coronal curvature is encountered, smaller diameter files should be used in step-back technique. Apical to the curvature will minimize the instrument stress and canal transportation. Rather than going with larger instrument for coronal shaping initially itself, you can use these type of more flexible, smaller instruments. A larger file will undergo excessive stress or likely transport the canal. And many coronal curvatures are not visible in the mesodistal plane. They may be present in the buccolingual plane. Then next scenario is file having the same diameter and the preparation result in maximum engagement. If you are inserting an instrument with the same diameter into a canal with the same taper, it may cause excessive stresses on the multiple points, which may cause us instrument separation. Then suppose if you are using a smaller taper file with a big tip diameter into a larger taper, what happens is that suppose if you are inserting a 30 file, 4% 30 file into a larger canal initially itself, the apical portion of the canal may be 20 or 25. So the 30 file will bind in that area, but the coronal part of the file will freely movable, so it will rotate. So in the apical part, the instrument binds and it may cause a torsional fracture. So what he put forward is a stone technique for canal preparation. Actually, the objective is to minimize the stress for any type of nickel titanium instrument. The idea is that the canal diameter should be large enough coronal to the curvature. In the coronal part, the instrument should not have any resistance, and the file diameter should not be large enough to rotate safely in the curvature. This was the idea of zone technique. So actually, he asked to determine the terminus of the coronal zone, that is the curvature of any significance and how far the curvature from the apex. So after the working length determination, reinsert the same file, and if you are feeling some resistance short of the working length, it is an indication of the terminus of the coronal zone. And he divided the root canals into two zones according to this terminus, apical zone and coronal zone. The green one is the coronal zone and the red one is the apical zone. Then how should we prepare the coronal zone? The file diameter file should be small enough to negotiate the entire canal, and the file should not have much resistance in the coronal area. So always have a pre-treatment plan. It should be a flexible plan, and always have a multiple options of instruments in your site. So basically, before going into the rotary preparation, you have to get an idea of what type of failures. One is torsional loading and one is cyclic fatigue. Torsional loading occurs if the apical part of the file binds within the canal and the coronal part continues to rotate. But cyclic fatigue is the result of continued forces being applied on an instrument as it curves. So in root canals with significant curves, cyclic fatigue is more common. I will explain with a video so that you will understand more clearly. This is called cyclic fatigue. So that is cyclic fatigue. This is another picture of cyclic fatigue. When the instrument rotates, the tension and compression alternately occurring at a different points, which may cause the instrument separation. So this is called cyclic fatigue, which is more common in curve. Next is torsional fracture. Instrument binds in the apical region, but freely move in the coronal area. You can see the plastic deformation that is occurring. In the torsional failure, you can see the plastic deformation also. But in the cyclic fatigue, usually you won't see any deformation. The instrument suddenly separates. So torsional stresses cause plastic deformation. Cyclic fatigue usually occurs without plastic deformation. So as the file progresses into a curved canal, the diameter that traverses curvature increases and file resistance to the fatigue failure decreases. So the length of the file that extends beyond a curvature is very important. That is why when you are instrumenting a long curvature or long root, you will get more resistance. For example, suppose you have done a very good coronal tapering with a 25%, 8%, 25 files. In the so the tip diameter till which 25% file has inserted will be 0.25. Suppose you are inserting a 2% 25 file 5 millimeter from the coronal enlargement, that diameter at that previous point will become 0.35 now. So even though you have used a 8% 25 file for coronal tapering, when you are going down with instruments, even with smaller taper, it may cause binding in the coronal aspect. So this point you should always have in mind. So when you are inserting a file into the apical plate, if you are feeling some resistance or from the coronal aspect, you have to increase the coronal flaring. So in instrumentation, you have to get a straight line access. Then you have to locate the canal orifice and do an initial hand file instrumentation. Then you have to do a coronal third flaring. Then achieve patency with hand filing. Then you have to refine the coronal shaping, working length determination, checking the canal configuration, then create a smooth glide path, then final rotary instrumentation and hand instrumentation. So in difficult cases, what you can do is that initial coronal enlargement with hand filing, that is 3 to 4 apical to the first point of binding, or 2 millimeter to the apical point of binding if it is an apical third curve. You can start with 8 and files, then 15 and 20, and even you can use 12 size intermediate size files. Then you can use, this is just my protocol, you can change according to your needs. Then ProTaper S1 universal, just short of first point of binding for coronal shaping. Then you can use SX for coronal orifice enlargement if you need, just 3 to 5 millimeter for in the coronal aspect. Then again, go with the K file into the mid-root region. Do not rush with the hand file into the apical third, because sometimes it may push the pulp tissue into the apical third. Go in a stepwise manner, especially in case of vital pulp. In non-vital tooth, it may push the debris also. So always go in a stepwise manner. Then if it is a very narrow canal, you use glider file like ProGlider for coronal two-third enlargement. Then after that, you can again increase the coronal flare using S1. Then again 4% 17 files. Then once the coronal two-third have been fined very nicely with the 4% 17 file, you can insert the hand file to length. Then take the working length with the apex locator and radiograph if you need. Then again, you have to advance with the rotary instrumentation to the working length. So you have achieved the working length, you got the patency, make a good glide path with the hand files, 10 files and 8 and 10 files. Then ProGlider to the working length, 4% 17 to the working length, then 4% 20 to the coronal two-third. Then if you need more coronal tapering, you can use 6% 20. Then again 4% 20 to the working length, then 4% 20 to the working length. Then 6% 25, if you need much more coronal tapering, you can use that. Otherwise, you can use nickel titanium hand file to circumferentially file the root canals, so that to remove, it will help in the removal of debris. So suppose if the 4% 20 is not going very smoothly into the apical thread, it means that you have instrumented 4% 70 into the apical thread. 4% 20, if it is not going to the apical thread, what you can do is that 4% 20 or 6% 25 for coronal flaring, and again insert 4% 20. For normal cases, you can rotary sequence, you can shift like this, S1 for coronal two-third, 4% 17 and 20, 3 millimeter short of working length, then 4% 17 to the working length, 4% 20 and 4% 20 to the 25 to the working length. But in very difficult cases, you have to use more instruments in a more stepwise manner. So this is a normal file sequence. difficult file sequence. Then you have to locate the second one is after access opening, you have to locate the canal orifice and initial hand file instrumentation. Then, as we discussed earlier, first point of binding with 10K file, assess the level whether it is coronal, middle, or apical third. Then no binding can occur in very large canals. So such canals will be much more easier. So after that, if you find some point of binding, 8, 10, and 15 files, 20 files should be used in a sequential manner, 3 to 4 millimeter or 3 to 2 millimeter from the first point of binding of 10K file. Always make sure that you are not going beyond the apex. So if it is an apical third point of binding, make sure that you have to use this file technique only 1 to 2 millimeter beyond that. In very severely narrow canals, you can use intermediate size file. What you are doing in this technique is that you have to create space for the rotary instrument, because rotary instruments, as you all know, they are non-active or passive cutting tips. Then again, you have to give a good coronal third flaring. So initially you have used the hand file 8, 10, 15, and 20 for coronal flaring. Then you are using a coronal third flaring using rotary instrument. You can use ProTaper S1 universal 21 mm, because even in large canals you can use 21 mm because you are not going into the apical third. And in very difficult canal access cases, you can use the ProTaper Gold also, because it may helps to slightly bend the instrument in the difficult cases. Then orifice openers like ProTaper SX, one flare, etc. can be used for orifice enlargement to remove the dentine triangle if you need. Always use the file in a anti-curvature mode or away from the furcation, and make sure getting this should come in straight way to the prospective cusp, so that you can make sure that you have eliminated the coronal curvature. So this is the picture. Your file should be come in such a way, otherwise it may cause unnecessary stress on the instrument. On my case where my access cavity and the coronal flaring was not adequate, I separated one instrument. Luckily I could bypass and avoid it. So advantages of pre-flaring, it gives better tactile control of the third, remove the restrictive dentine and deeper penetration of the irrigation solution, decrease the post-treatment problems. Then working length is less subject to the change as the instrumentation progresses. Then reduce the risk of ledges, transportation, stripping, fracturing of the instruments, etc. This is the picture you can see. Because of the inadequate coronal flaring, I separated one instrument. Luckily, I could bypass and remove the instrument. Then after that, reach into the apical third. After coronal flaring, you have to reach the apical third with the 8-10 file with the envelope of motion or watch winding motion, the working length. Then file lubricants can be used in this hand file technique, because it will remove the debris very easy. Because many times if it is a vital pulp tissue, there will be a lot of pulp tissue. And if you are using EDTA gel, it will help in the emulsification and removal of this pulp tissue, and it will prevent the extrusion of the pulp tissue in the apical third, and it will prevent the apical blockage also. So when you are using initial hand file negotiation, you can use slightly coat the instrument with EDTA gel. Then you have to create a smooth glide path with the initial with the hand files, then with the rotary instruments. Actually, if you are sometimes if you are using EDTA gel, it will help in the lubrication, emulsification, and flotation of the vital pulp tissue. So it will prevent the blockage. And many times in the initial stage, the irrigant will not reach the areas. So you have to use the EDTA gel. But once the canal has been enlarged, you can use the irrigants also. So once you reach the apical region and achieve the patency, you can determine the working length with the apex locators or radiographs or both. Then do a repeated patency filing with 8-10 files and make sure them super loose. And slightly overdo the patency in very narrow canals, and clean files in between with alcohol dipped sponge or gauze, and again recapitulate it again with the 8-10K file. Always recurve, re-lubricate, and reposition in between. Irrigate also. This is the picture that shows the importance of apex locator. Then reciprocating hand wheels for hand files can be used, but I usually prefer hand filing only. In very difficult cases, you can use this one also. This is a picture that shows if you are directly going with a K fiber 10 into the apical region, it may cause the pushing of the apical pulp, cause blockage, and cause postoperative pain. Then always try to find the confluency of the canal, type of the canal configuration before introducing the rotary instruments. So this is called confluency or merging of the canal. Usually mesial roots of the lower first and second molars, MB1 and MB2 canal, maxillary premolars may have confluent canal. Usually if you are instrumenting with the rotary instrumentation in confluent canal, sometimes it may cause instrument separation. So you have to restrict the rotary instrumentation to the straight canal and restrict the instrumentation to the coronal point in the other canal. The most commonly confluent canal can be seen in this type of roots. A confluent canal you can check by inserting two instruments simultaneously inside the canal, but sometimes it won't work. If it is a very large canal, both of the instruments will go, even though if it is a confluent canal. Another way is to, suppose if it is a mesial canal of a mandibular molar, usually mesiolingual canals are much more straighter than the mesiobuccal canal. So if you are doubting a confluency, instrument the mesiolingual canal first, and in between, in mesiobuccal canal, you can do the patency filing, but do not insert any rotary instrument. Then after the mesiolingual canal preparation is over, just insert a master cone in the mesiolingual canal and insert the 10 or 10 or 15 file into the mesiobuccal canal and remove the GP, so that if you are seeing such indentations, you will get a point idea where these mesiobuccal and mesiolingual canals are joined. So first instrument the main canal, that is the straighter part of the canal, mesiolingual canal, then insert the master cone and then try to get these marks. Or else try to insert the master apical file. Suppose you have prepared the mesiolingual canal till 4% 30, insert a 4% 30 or 30 file inside the mesiolingual canal, then insert the 10 file into the mesiobuccal canal and reevaluate the apex locator value. If you are getting an apex locator value short in the mesiobuccal canal, it may be a merging canal and you will get the point of merging. So once you achieve this super patency, you have to refine the coronal shaping. You can use the S1 type of or 4%17 files for coronal shaping, because many times you won't get patency many times initially. So if you are not getting patency, be patient and again do a good coronal flaring. You can use 4%17 files, S1 files or glider files and make this straight way till the apical curvature. And then again try for the patency. Here you can see in the mesiobuccal root, actually instrument was going into the, not going into the apical third initially, even after pre-curving. So after the good coronal flaring with 4%17 files, I could get the patency. So after gaining straight line access, try to go for A10 file with 10 file into the apical region, check for patency, determine the working length, achieve the initial glide path, and try to get an impression of the canal. In multiplanar curvature, when you are taking out the 8 and 10 files, you will get the idea of the curvature, because many times you will get the impression of the curve in the instrument itself. When you are taking the 8 and 10 files out of the canal, you will get the type of curvature imprinted on the instrument. Then rotary glide path. After the initial glide path with the hand file, you have to create a rotary glide path. So for that, you can use rotary glide path instruments. This will make easier to negotiate the canal and curve with subsequent instruments. So there glider files will be different types of glider instrument. It may be a single type of instrument or a different type of file system. It may be a single file system or a different file system. So what do you mean by glide path is, it is a creation of smooth radicular tunnel extending from the apical foramen to the orifice. So different types of glider files are available. Protaper glider files. Oh, excuse me. Daddy, turn. കാരണം ഉണ്ടാവില്ലേ? 10 minute ഇവിടെ പറ്റുന്നടി you can use these hand files for hand file adapter for converting rotary into hand files. Then always make sure that you are instrumenting in the presence of irrigation, because when you are instrumenting in the presence of irrigation, it will reduce the instrumentation stresses. And always have an idea what type of instrumentation you are using, what type of file diameter it is having. So if you are using these type of files, you should have a mental idea of what type of tip
I think the faculty's net is down. He will join very soon.
Hello, am I audible?
Yes, doctor, you can continue. You are audible.
Hello.
Yeah, you are audible. You can continue.
Hello.
Hello.
Sorry,
Hello.
some KSEB work is going on, so
Okay.
sorry for the interruption. Yes. Hello. Tapers in canal with sharp curvature. And so if it is a very narrow canal, it is preferable to go with 4% taper files. And also you can use 2%, 20 and 25 files after the final rotary preparation to loosen the debris. So no need for further coronal enlargement. So nowadays good irrigation needles like true anatomy are available, which will very easily go into the apical thread preparation, even with 4% So if your true anatomy needle goes into the apical 3 millimeters of coronal enlargement. So irrigation, as you can see, this is anatomical complexities. Irrigation is very important. The irrigation solutions are 17% EDTA, 2.5 to 5% of hypochlorite. Fluoxetine can be used chelating agent, which can be mixed with hypochlorite as a association. I use EDTA gel, so it will help in the removal of the pulp tissue. The normal cases almost most of saline inside the canal. EDTA aqueous solution for the coronal thread enlargement, If it is having a position, you can use aqueous EDTA for the coronal But if it is a wide canal with a young pulp, lot of pulp tissue, in such cases, there won't be much resistance to the rotary instrumentation, but the tissue. In such cases, you can use the EDTA gel for the initial rotary files. First 1 or 2 rotary files, you can use the gel. Make sure that you have removed the gross amount of pulp tissue from the root canal. After that, you can
Sorry for the inconvenience. There's some net problems at the speakers area.
Am I audible?
Yes.
Sorry. Am I audible?
Yeah. Now we are audible.
Yes, sir. Yes, sir.
Hello. Am I audible?
Yes, sir. Yes, sir. It's you're audible, sir. You can continue.
So final. Yeah. So in this step, you have to make sure that you are using adequate volume of irrigation. You use at least 15 to 20 ml of. Yes, thank you. So in this step, you have to make sure that you are using adequate volume of the irrigation, that like 20 to 25 ml of irrigation you have to use. Then final irrigation, just before the operation, after taking the master cone, you can use the EDTA gel, 17% EDTA gel for 1 to 2 minutes, smear layer. And after that, you have to again use the pipe to agitate. Once the EDTA has been, the hypochlorite with some, then if you need, if accident, always make sure that you have removed every remnants of hypochlorite, which is not advisable. It's a separate syringe and needle. Wash out the hypochlorite before using chlorhexidine. Then always use lever lock syringes. 5 ml is the Hello. Sorry, can you hear me?
Yes, doctor. Continue.
Am I audible now?
Oh, you're audible.
Sorry. Then sorry. Always use side bending needles. Also, and the main problem with the side bending needles are the lumen size is very small, so that they will clog very easily. So you have to use the in order to avoid spillage of the irrigation also. Manual dynamic agitation is one of the most cheapest way of doing agitation. You can use your master cone 1 mm short of the working length, or trim the 1 mm of your master cone to agitate the irrigation solution. It will help the flow of irrigant into the apical region. So it is one of the must technique to do the agitation of the irrigation solution. Then passive ultrasonic irrigation, you can use U files. U files are similar to K files. Different sizes are available. Usually 15 and 20 and 25 can be used according to the sizes of the canal. And they can be attached to the U file holder with some specialized chuck. And they can be attached to our normal scaler unit. And it can be used at a lower power. Very low power. You can use these type of U files to agitate and activate the solution. It will cause acoustics, and it is a very efficient tool for agitation and irrigation activation to warm the hypochlorite also. But main problem to insert into a narrow or curved canals. So in very irrigation, and if you're having a satellite device, you can use this type of devices, but it is not compatible with the other scalar unit called Irrisafe. Then cordless devices are available, but they are more expensive. You can get the same effect with this passive ultrasonic irrigation, which is much more cheaper. Then sonic devices like Endodontic sonic irrigator are available. They are use plastic type of devices. They are very useful even in curved canals. So in very narrow canals and posteriors, you can use sonic irrigators. They are much more safely, can be much more safely inserted even into a narrow canal. So what I usually do is that in narrow canals, I use these type of sonic devices. Then another option also economical alternative, and this also it is also use metallic tips, not to save you use them safely in curved canals. Then negative pressure irrigation solutions are devices are available, much more expensive, and either the sonic and ultrasonic activation should be tried only after final shaping, because the canal should have adequate size in order to insert this file to get these movements. So which or agitation device should be used first? Sonic activation and pads, I would recommend. You can use sonic activation 11,000 rupees only. Then U files, very cheap. You can start with U file agitation or sonic agitation. Hypochlorite, you can agitate with manual dynamic agitation, either sonic agitation or pads. Passive ultrasonic irrigation is very, say, posterior or narrow canal, you can use sonic agitation also. Then these are some of the endo aspirator tips. They are very useful. Prevent the irrigation flow out from the pulp chamber, so that the patient won't feel any taste difference. Metallic aspirator tubes are available. Then if you are not using rubber dam, you can use if we are doing a you can use these of irrigant volume of irrigation, time of contact, frequency of irrigation. These are very important. In my earlier days of practice, I was totally ignoring the volume, time, and frequency of irrigation, and I paid the price for that also. I have faced many failures. So irrigation needles also very important nowadays. Lot of good needles are available. So their type and gauge is very important.
Sorry for the inconvenience made. നമ്മുടെ സ്പീക്കറിന്റെ അവിടുത്തെ നെറ്റ് അവിടെ some work is going on over there. അതുകൊണ്ട് അത് കട്ട് ആയിട്ടുണ്ട്. So he will be stopping it right now, the presentation. He'll join us just for a discussion. Members, if you have any questions, kindly post it in the chat box so that we can have a discussion right now.
Hello.
ഹലോ ഡോക്ടർ ഫ്രൻസി കേൾക്കാമോ? ഹലോ ഡോക്ടർ ഫ്രൻസി കേൾക്കാമോ?
ഹലോ
ആ പറഞ്ഞു ഡോക്ടർ, കേൾക്കാം ഇപ്പം.
അപ്പൊ നെറ്റ്വർക്കും പോയി കിടക്കുക. ഏരിയൽ മൊത്തം മെയിൻ്റെനൻസ് അടക്കാൻ തോന്നി. മൊബൈലിലും കിട്ടുന്നില്ല. ഞാൻ ഹലോ ഹലോ